Great. Thanks, Chris. Well, next we'll hear from Roy Grant. He's consultant formerly at Children's Health Fund. Roy is a collaborator with Dennis Johnson, whom we heard from yesterday. And Roy, we have the tool right here for you.
Okay, I have to say that this wasn't planned, but the transition from that presentation to this couldn't have been better if we had thought about it. I'm going to be looking at data that demonstrate the extent of the problem of lack of transportation and healthcare access. When you heard from Dennis yesterday, so I'm not going to go into how we got there, but when we started to look at what's the extent of the problem, the data were horrible. I mean, we all know weasel words, as many as, nearly. I was coming across millions and millions, and millions and millions and millions of people are affected. There was no specificity. Definitions were all over the place in terms of what constituted the term that was used was transportation disadvantage. The definition on that was a little bit too broad. So we got involved in a series of national surveys, working with initially Zogby International, and we later settled with Marist College Institute for Public Opinion, the famous Marist poll people. And the first thing we learned is that there are areas that are much more affected, poverty, of course, rural, of course, so we needed to do some targeted data collection as well. So we got involved as well with the Delta Rural Poll at Delta State University in Mississippi. So this is a composite of the data that we have. It's important to look at the dates here. We were 2000, we didn't use Zogby because that was 2001. But the dates here are 2006 and 2010. So this is like a baseline of what things were like before the Affordable Care Act. But this is a very propitious time to refresh these data, and the questions are preserved, the SPSS tables are preserved, so we could do some really good trend analysis. But looking at public transportation, 39% of US residents did not have public transportation. 11% of households did not own a working vehicle, very carefully worded. So if you have a car, but it doesn't work. If you have a van that's not a car, that was counted, very carefully worded. Personal vehicle ownership, 11% did not. But this was a little bit of a surprise. We asked a very specific question, follow-up question of people who had public transportation in their community. Can you use it to get to your usual source of health care? And only 42% said that they couldn't. In rural communities, only 14% could. So there's a huge problem, not only with regard to access to transportation, but specifically access to transportation for health care. This shows by type of area of residence. You can see automobile ownership. We didn't have a special place for New York City on this, but other than really large urban centers, you can see that that's pretty flat. There's no statistical significant difference among the different areas of residence, whereas when you look at the downward slope of public transportation, clearly significantly less available in rural communities. We were, of course, Children's Health Fund, so we were looking at things in a pediatric perspective. And again, these were very carefully worded questions, and the criterion we set for having a transportation-related access barrier was, did you miss an appointment within the preceding 12 months because transportation was not available? So looking at nationally, 4% of children, which is actually more, with 75 million children, that's actually more than it sounds. But this number, the number below it, 9% in households with incomes below $50,000, that's been a stable number through that entire decade. And that's really clearly where the target has to be. And again, very carefully worded follow-up question, did you later seek emergency care for the condition associated with the missed appointment? So it wasn't like, a week later he fell off his bicycle and needed to go to the ER to have his leg x-rayed. It was very specifically the reason, the presenting problem that they couldn't get to primary care because of transportation. Nearly 1/3 later used the emergency room. So applying census data, that's 1 million potentially preventable pediatric ER visits. So we use those data, and this is where there's a real synergism with the previous presentation. We use those data to develop an index to target areas that are at high risk for transportation-related access barriers. And those are the criteria that we use. It's a validated protocol. It's scored. The sum of the scores is a point score from 0 to 14. Greater than 7, 8 or higher is high risk. The definition we used for high risk in the validation study was having the top quartile rate of ambulatory care sensitive condition hospital use, ER use. That's what it looks like. It's probably still too small to see, but it's a score sheet that gives you the criterion, and the point score at the back suggests data sources that you can use. Part of the way that we selected these criteria was we wanted to make sure that these were data that people could get without going crazy and having a search party for 6 months. And there's a lot of data that are much harder to get than area poverty rate or something of that nature. So what we did next, and this is where the community commons could be quite useful. We used GIS software to map each county in a state, and we looked specifically at safety net clinics, and that's the definition of what we included. We did do a pilot where we included physicians in private practice. It didn't change the outcomes in any way, and you don't want to do that if you don't have to. Not to mention, if you're looking at safety net, you then have to vet each provider. Do you take Medicaid, or are you accepting new Medicaid patients? It changes nothing and adds to your workload enormously. So we focused on the community health centers, broadly speaking, safety net hospitals, which are a major resource in some rural communities, and local health department clinics, which is an interesting thing to look at because some of them do not provide primary care. Some of them provide immunization or some other special purpose, so those you have to vet to make sure that they're open to the community and that they provide primary care. We used the software to draw down census data by census block, and then if you're a mapping person, this will make sense. If not, ask me about it later. We calculated the population-weighted centroid, and we then did a vector straight line distance from the population-weighted center to the nearest safety net clinic. And that's an example of what we ended up with. Everything I'm going to be showing you now is state of Tennessee. And so you see how close the nearest clinic is to the population-weighted center. And this was true. We only did actually did Michigan as well. We did 3 states, and one of the overriding things that we found is that these federal 330s, the community health centers, are exceedingly well located relative to population centers. If NAC is in the room, it's extraordinary how important and how useful these clinics are for these high-risk populations. But you can see that there's some distribution in this county elsewhere. Population center, well, you'll see in the when we come up with what the distances actually look like. We did an analysis of the high risk, as I defined, the high-risk counties against the rest of the counties in the state to look at what their characteristics are. These are highly statistically significant, more rural, and a proxy for that is lower population, higher poverty, and really the criterion is 1.25 times the national rate was a red flag. And just a little bit about workforce shortages. There was considerable overlap with designated health professional shortage area status, but it wasn't as one-to-one as you might have expected. We highlighted areas that were not HPSAs. Some HPSAs were in much better shape, and this just seems to be a more discrete way to highlight areas that are in need of service than the HPSA designation, and that's something that's worth talking about offline from this. So all of these were very highly significant between the high risk and the other counties, but not distance. And when we looked at transportation resources, 80% of these high-risk counties had paratransit services. This scatter plot shows you distance against poverty rates. So you can see the strong cluster of these straight line distances within 10 miles. And so for planning purposes, it looks like the majority of population can be accommodated with vehicular transportation within a 10-mile radius of a safety net clinic, which does not sound like an insurmountable problem to do. A lot of it is within 5 miles, and if you look again at the y-axis, the highest poverty clinics, the highest poverty counties had the shortest distances, which is also refreshing in terms of the planning possibilities. So we came up with, we also actually looked at what's in the literature of effective strategies to harness the county asset of paratransit services. And these were some models that have some proven track record. Modifying paratransit services to include some scheduled stops, population center, and health clinics, so you deal with that problem that the transportation isn't really useful to get to the health clinic. Or the other problem with paratransit is you have to call 24, 48 hours in advance. It's not useful if you have to get to the doctor now. Then there are some counties where contracts would develop between the county or the state to make use of paratransit services specifically for healthcare access. And the third one, and again, another discussion that's worth having, but offline from this, is that the mandatory Medicaid non-emergency medical transportation system is not working optimally at all in many counties. And so using existing public transportation services to strengthen Medicaid NEMT can be useful, especially since the rides are potentially reimbursable by Medicaid. Oh, and that's, that's my contact information if anybody wants more information.